Thank you. Okay. Pharmacy quality measures. Now, I've spoken about this quite a few times with NPS, NPSC, as also with HealthMart. So I'm hoping you're pretty familiar with it now. CMS has been using these for a while, but we'll talk about what they are, what the 5 of them are right now, why it matters, and how you can improve it, which is the important thing. I do not have any conflicts of interest. I will say, though, that for the last 2 years, I did work with HealthMart, giving a similar presentation to their franchisees. So I may mention some programs that HealthMart might have, and I'm certainly not here to push HealthMart. I mean, I'm just familiar with them, and I'm sure there are other organizations that have similar programs. So if I do slip up and mention that, I apologize, but I'll try to keep it neutral. Quality measures, and what will the future bring? It's a little different, why they matter, and then how can we improve it. So the 5 quality measures that are being measured right now are the RAS antagonists in use in Medicare patients with diabetes and hypertension, medication adherence, as is measured according to PDC, which is proportion of days covered for 3 different drug classes, the statins, the RAS antagonists, and the oral hypoglycemic agents. And just so we're talking the familiar thing, the RAS antagonist is a terminology for drugs that work on the renin-angiotensin system. So your ACE inhibitors, your ARB, your blockers, your angiotensin blockers, and then your direct renin inhibitor, which is Tecturna. And then the last measure is the high-risk medication use in the elderly, which are people 65 and above. So those are the 5 things that are being measured right now. 3 of them, 4 of them we want higher is better. So the top 4, we want a high number. The last one, high-risk medication use in the elderly, we want that as low as possible. There'll be someone talking about that tonight. And there's 3 of these that we have direct input over, which is proportion of days covered. The other 2, we need physician authorization, whether to start a medicine or stop a medicine. But the middle 3, proportion of days covered, is something pharmacy has direct input on, and you can make improvements. So, medication adherence, how is it measured? This is my, first of all, it's a Medicare patient filling at least 2 prescriptions, so they don't start counting until there's a second refill, and drugs in the same therapeutic class. So if we're talking about statins, and medication adherence, it could be someone who gets atorvastatin filled twice, or it could be someone who got, say, simvastatin the first time through, had a side effect, and then the physician put them on Crestor, because that's in the same therapeutic class. Okay, so once you get that second refill, now you start measuring adherence. It's measured as proportion of days covered, as I mentioned. And how we measure it, or how it's measured, is think of a 30-day fill, 30-day prescription, and we're going to look at 180 days, so a 6-month time period. So if you get that prescription filled 6 times, so the denominator is the 180 days, the time period. If you get that prescription filled 6 times, that's the numerator, you got 180 pills. So you got 180 divided by 180, that's a PDC score of 1.0, you're 100% adherent. That makes sense, right? Take your pill every day. If for some reason you only got that prescription filled 5 times in the 6 months, that would be 150 pills divided by 180 days, that's a 0.83. Okay? So that is considered adherent. We'd want to get the 0.83 if we can. If you can do that, that's what CMS considers adherent, anything above 80%. When it comes to chronic care medications, diabetes, hypertension, statins for cholesterol, Medicare patients average 62% for PDC. So So there's a lot of room for improvement. And for pharmacy, that means over the course of a year, you're losing 4 refills that you could have filled. That's 4 refills that you could have made profit on. And you can also improve the health of your patients and save everybody in the healthcare system money. So are we all set with that? Yes?
Does it look at the name of the medication specific, or if it's, what is the, let's say you're looking at statin, we'll switch to a different one?
As long as we're staying in the same therapeutic class, it'll look at it. So if you're switching from simvastatin to torvastatin, it'll just continue right along. That's fine. A patient will drop out if they haven't filled for 45 days, because CMS is going to assume they stopped the medication, or maybe they were in the hospital and then rehab. So patients can drop out. A common question is, what about the snowbirds, people that go away for the winter? And that pretty much gets assigned to whoever fills the most prescriptions for that patient. So if someone's in Florida for 6 months and up here for 6 months, even though you don't have control over the whole time, it may get assigned to you. They've got to do something, and that's what they rule. Whoever fills the most prescriptions. Oops. One of the goals, the high-risk medication use. All right, so that's the one we want to keep that lower. It's the 2014 American Geriatric Society high-risk medication list. Very similar to the Beers list. So for some of us older people, we learned about the Beers list in the early 90s, which are medications we were not supposed to use for patients in the hospital. The HRM list is a little bit more expanded. Let me mention this now before I forget. My Health Mart plug, but Health Mart has put together what they call the playbook. And in here, there are a list of medications. So like they have a beautiful one-page list of the high-risk medications that you can keep it near your computers in the work. If you want one of these, and you don't have to be a Health Mart to get one, you can just visit the booth. I do have tickets up here that you can come get and hand it in at the booth, and they'll just give you one of these. I'll talk about this a little bit more later, but it has a lot of nice things in it. So the thing with the high-risk medication use, you're allowed 1 refill. So you can fill it once, and it's not a problem, okay? Because things happen. People get released out of the hospital or out of the ER. They may need to start their medication right away. It's the second fill. Once the second fill is hit, then essentially you've been dinged, and whatever you do after that, it doesn't matter. I mean, obviously, there's a reason why we don't want these patients on these medications, because there usually are better choices. But so the sooner you can get someone off, the better. But as far as this measure, once the second fill has happened, that's when you get dinged. So prevention. If you can prevent the first refill, that's the best thing. Or at least, if you can prevent the first fill, or at least the first refill. In 2014, for the PDP plans, the 5-star goal, so the top number, they wanted people's numbers less than 3% for high-risk medication. For 2015, it's been raised to 7%. The reason was 3% just wasn't realistic. Even though ideally they would like that, most people are around 10 to 12%. Does anybody get measurements on what the percentage of high-risk medications are? Are you under 10%? Right. Yes?
What happens if you fill it the second time? They refuse it, and it's filled out in full retail. Is that pay you, or should you just not send it through and just bill it for cash?
CMS can measure. You're supposed to be submitting cash prescriptions. That's right.
But if
So
it's going to go against you, you're going to charge them the full amount anyway because they're not covering it. I just,
right.
The third time.
I'm pretty sure most of the contracts read you have to submit the claim, even if it's a cash claim. Now, I know there are people that don't do that, and that's fine, but you're supposed to be submitting the claims at least so they can track them.
So what happens to the third time? Should you just keep sending it to them and they'll just...
You can't get double dinged. So you get dinged, and then that patient that's been measured. So, yes. Thank you. Excellent question. Insurance plan and physicians are also being measured on this. Now, they have many more measurements than we do. We only have 5 right now. And they have many more, but they are being measured on if their elderly patients are taking high-risk medication. Insurance plans, that's part of their quality measure. So that's why a lot of times it's insurance-driven. You might get a Marixa or an outcome message telling you to try to do something about this patient on a high-risk medication. So even medication adherence that a doctor doesn't have direct effect over, they get measured on that by how well their patients perform. If you have a patient with diabetes, is their A1C under control? That's what they get measured on, but a lot of it has to do with whether they take their medication or not.
So what's their, I mean, for us, we want to be in preferred network.
Right.
Physicians, what's their...
They get their reimbursement.
Okay.
They get quality reimbursement or they get bonuses, essentially. And same with insurance plans. There was a question over here? Yes?
A couple of things. Medication adherence, I think 80% is the magic number. So if I'm running a mail order operation and I'm sending stuff out whether the person orders it or not, it's getting delivered, I'm going to look great, aren't I?
Yeah.
Whether they take it or not is irrelevant.
You have no control over that. There's nothing we can do about that. That's what mail order companies do. Let's acknowledge that. They auto ship. But, you know, we're also trying to improve patient outcomes, right? Our patients are our friends. They're our customers. And we're trying to improve, and the way to get improved outcomes is to make sure they take their medication. I mean, that is the single most important thing that, especially as pharmacists, we can do for them and ourselves. Yes?
This is one thing that really bothers me. I was speaking to a major cardiologist from North Shore, the Boston area. And we have in the Boston area some of the best doctors in the world. And he gets insulted when the insurance companies call him and tell him how to treat his patients. And the same thing with Marixa. It really bothers me that Marixa people want me to call a doctor, and I should tell the doctor what to give his patients. Doctors don't like that. And I don't know why people who sit behind those desks and do work and don't realize this. They're trying to be God, and they can't
Right.
be. The doctor's God.
Okay, so I think that's probably the biggest complaint with the high-risk medication measure is we get the call from Marixa, we fax the doctor and ask, can we reduce the dose of digoxin, can we change this oral hyperglycemic agent, and they refuse. Well, that's all we can do. We're not God. We're pharmacists, and we have to go by what they say. If I was a physician, I wouldn't like it either. But this is the game right now, and we're in the game, and we want to stay in the game. I'm going to go there first, and I'll come back to you. Yes? The American Geriatric Society are the ones who determine what's a high-risk medication. So a lot of them have anticholinergic side effects, right? And you can get confused with dementia. I mean, but, you know, that's who makes that determination. Right, well, that's all you can do. And if you have a heavy population of seniors and the doctors won't change it, you might not be able to but believe me, you're not the only one who can't move this number. Remember, it went from 3 to 7% because nobody else can move it. So they had to come up with a more realistic number. Yes?
We're not the first ones calling on. They're hearing from the insurance company, and we get them. In a lot of times, the conversation I've had with the isn't very good. They understand, they're getting hit. You understand how they pay and how the bonus is. They're getting hit with it. It's coming out of their pocket. And a lot of times, I've had a conversation with it actually, thank you, Colin, let's switch the patient. So it's something that's rewarding. If you call and you have the right, the right presentation, instead of calling it,
Right.
oh, I understand, doctor, this is what you have to go through, but if you basically have the information available when you call the doctor and have a game plan in place, it's no big deal.
Right. I mean, I certainly get it. Their time is pressed. They're arguing for prior authorizations on drugs and for MRRs and try to get someone to a specialist. And they're getting called from the insurance companies about other things. And here comes the pharmacy giving them a notice that the person should be on glipizide instead of glyburide. All right, but that's what we're trying to do, and there's a reason why, because glipizide has a little shorter half-life, so you're less likely to get hypoglycemia in the afternoon. And if somebody's 80 years old and has hypoglycemia, they fall, they break a hip. Now it's a major problem. So there is reasoning behind why we do what we do, but I certainly understand the frustration that both you as pharmacists feel, because you're trying to do your job, and not only are you getting sometimes just stopped, but also taking grief back, but also for the physicians. How, they got into medicine to practice, to help people, and that's just not what they end up doing now. They push paper. They're very frustrated. Yes?
Their electronic ordering systems don't tell them what's on the peers list or whatever the new list is called for the insurance company's formulary. Why does it get to us in the first place?
I don't know what their electronic ordering system does and doesn't. And I often wondered why they didn't do that. And David, why aren't high-risk medications on prior authorization? Come on.
We can't do it.
Okay. So the question was, why aren't high-risk medications on prior authorization from the insurance company and then alleviate the problem? Right. Or you... I thought you told me once that Express Scripts said they're getting a lot of pushback from the chains because they don't...
They would interrupt.
Right.
So it's a big economic issue with chains.
So, I mean, that's an honest answer. It may not be a good answer, but, there's pushback. Yes?
What are being measured for our success in changing patients to a non-high-risk medication? Is there any measure for us making the attempt and the doctor says, no, I don't want to change it?
There's none that I know. Oh, so the question was, if you try to change someone from a high-risk medication and the physician says no, is there a way that you can document that and essentially, get a good effort for trying? And the answer is no. There is no. You can't say I tried. It doesn't work. So I won't spend a lot of time on this, but what is the future bringing? Because, we're already in 2015. The bids for 2016 go out in a month or so. Statin use in diabetes, okay? That's going to replace the RAS antagonist use. The RAS antagonist use in diabetes is being retired. It's being retired for a couple of different reasons, but this is the last year for that. It's going to be replaced by statin use in diabetes. All right, so that's coming in 2017. It's going to be a display, and a display means they're going to do a benchmark. And so what is happening right now is going to be the display measure for 2017. What happens next year is what's going to be the first measurement year. Okay, so this stuff is happening. It's going to go on right now. So that's one change. Completion rate of the comprehensive medication review, which is that MTM therapy that takes an hour, where the patient's supposed to leave with an action plan and a list of their medicine. Okay, the completion rate of those that are supposed to be done, that's going to be a measure in 2000, starting next year. Okay, CMS wants these things done because they're proven to save money in the long run. Okay, so you should start working on a plan to try to get these done. They're getting done at about a 10% rate right now. So out of all the people that are eligible for these, only about 10% are getting completed. A lot of different reasons for that. They're not all getting down to the pharmacy. Some of the insurance companies, because the insurance companies are trying to figure out how to do it in-house, but the most effective ones are done face-to-face at the pharmacy. So that's going to become a completion. That's going to become a new measure. The good thing is, in the beginning, it's not going to be measured as heavily as medication adherence. Medication adherence is triple weighted in the measuring, and this is only going to be a single weight. Opioid use, okay? Huge problem, if I don't have to tell you all. They're looking at ways of trying to identify people that go to multiple doctors or multiple pharmacies or on high doses of opioids that don't have cancer or hospice. Okay, so those people are going to be pushed aside. And, you know, just to put on my inspector hat, this is the #1 public health problem in Rhode Island. It probably is in the rest of New England, if not this whole country. Use the PMP system. Okay, pharmacists are being held responsible if you don't look at the PMP system. We've opened 12 complaints against pharmacists for not looking at the PMP when they should have.
Do you know if the states are going to get more real time? Like the state of Connecticut is 2 weeks behind.
I can't address Connecticut. We're 72 hours in Rhode Island. There are a few states that are 24 hours. One of the big problems is Connecticut and Rhode Island talk to each other because we're on the same system. Massachusetts uses, is it called NARCHEC? Do you know the name of your prescription? It's Atlantic? Okay, so it's a different platform. So, you know, that's kind of a problem, and they're trying to work it out. But so I don't want to spend a lot of time on this, but I do want you to know that I can run a report that tells me if you looked at it or not. So you need to have your own login, and you need to start using it, because if you do an early refill, you may get called before your board to explain why you didn't look at it. Yes?
Not to belabor medication therapy now, but we had a case where we called the person, we had like 8 days left on. When I called the lady to schedule an appointment, face-to-face appointment, she had told me CVS already had contacted her, asking her for the same type of thing. She swore to me she only had one prescription ever filled there. The shit that they got to her before me. Now, why are patients being assigned multiple pharmacies?
I don't know. Dave, do you know? You couldn't?
That's a question none of us here are going to be able to answer. We all
Right.
agree. We don't know what the answer is.
So I guess maybe to try to be proactive is you want to jump on these as quick as you can, just like the targeted medication reviews. The drug-drug interactions are being measured right now, and that means what do you do? What does your pharmacy do when you get back the DUR that says there's a drug-drug interaction? Is your pharmacist looking at it, or is some technician just blocking it away? So these are reports that you can run from your own software system to make sure they're being looked at, because it's a liability issue. I put in there reduction in fee. I don't know what your fee is going to be in the future. I hope you all know by now, because I preach it all the time. As a member of Northeast, you belong to NCPA. NCPA, the National Community Pharmacists Association, is the one national organization that is out there fighting for independent pharmacy. You get many benefits. One of them, I get an electronic email every Friday from the president, Douglas Hoy of NCPA. This was from the January 30th, 2015 electronic newsletter. The Department of Health and Human Services has set a goal in less than 2 years of tying 30% of traditional fee-for-service. That's what pharmacy works on. You fill a prescription, you get paid. Fee-for-service. 30% of traditional fee-for-service Medicare payments to quality or value through alternative payment models, such as accountable care organization or bundle payments. And then he says, pause and reread that. That was actually in the article. And the goal for 2018 is 50%. So I've been asking people, well, what does this mean for pharmacy? Because doctors work on fee-for-service, hospitals work for fee-for-service, physical therapy, x-ray, everybody works for fee-for-service. So no one's really been able to tell me what it means for pharmacy. But quality is going to come into it. And how you perform on those 5 quality measures is hopefully going to allow you to get a better payment than would be if you can't perform on the 5 quality measures. I was sick one day and I was home watching on the local TV station, and they had business leaders and healthcare leaders in Rhode Island talking, and Rhode Island Blue Cross, this was independent, said in 5 years we want to have at least 50% of traditional fee-for-service gone. So the business model is changing. It might not be 2016, but it's coming real quick. And quality counts. So if you perform well, you can be part of the preferred networks. Now, that can be a two-edged sword, I know, because a lot of times in Medicare, to be part of a preferred network, you're going to accept a lower copay, or you might have that DIR. But the thing is, customers, Medicare patients, love preferred networks. 87% of Part D plans offered at least one preferred network choice. And over 80% of the Medicare patients in the Part D plan selected a preferred network. Now, just so we're talking the same thing, preferred network it's a lower copay at one store, and I think of the Humana Walmart. So it's a lower copay at Walmart than it would be at my store. They can still come to my store, but it might be $5 for a generic at what used to be my store, and it's $2 at Walmart. Okay, so you're still allowed to play in the game, but and sometimes they call it a preferred cost-sharing network. Okay, so there's tremendous, and we learned this year, right? There was that whole Aetna mess where pharmacies that thought they were going to be in the preferred network plan weren't in the plan, and CMS had to get involved, and Aetna actually got fined because of miscommunication. But the thing is, if you're not in the network, they're not walking through your door. Okay, so to be in a preferred network, quality is the best area that independent pharmacy can be involved. It's how you do on those measures. Because you have a relationship with your pharmacy customer. They're your friend. They're your neighbor. You've been dealing with them for 30 years. Chains don't have that. Chains is a transaction, right? Somebody said, customer service is so bad, like the gentleman said, you're happy to go check yourself out in the store now, so you don't have to interact with it. That's kind of what chain pharmacy is with this. But you have this relationship so that when you talk to a customer about a high-risk medication, they're more likely to take the action. When a chain pharmacist goes out and talks to them, they usually say, okay, I'll talk to my doctor. And they don't want them involved. So you really have a huge advantage to be able to help yourself as far as when you talk to people about medication adherence, when you're talking to them about starting a medication. just a little continual. As the preferred networks get smaller and smaller, and you're in the network, there's going to be more customers that you can grab, right? If there used to be 5 drugstores, or if there are 5 drugstores in your town, and 2 of them aren't in the plan, then all those people that went to those stores have a chance to come to you. Performance is our best measure. Better clinical performance means you're selling more prescriptions, right? Better your patients are taking their medication adherence, you're selling them more prescriptions. When you're in the network, you can sell them other things like MTM. You get their targeted medication reviews. You can do immunization. All these little things that we now need that help you supplement the income on the prescription side. And it makes your customers stickier. That's the term that people use a lot, which means they're more likely to come to you because you're giving them more. If you're giving them their prescriptions and you're doing their immunization and you're doing their MTM, there's a much stronger attraction. And conversely, if they're getting their prescriptions filled somewhere else, but you do a CMR for them, that gives you a chance to pull them in as a magnet. So that's kind of where the future is and where we're going to go with performance networks. How many people here are signed up with Equip? Good, good. How many people look at what they get from Equip? Does anybody want to comment?
They're behind.
They're behind. How far behind?
I think they're like 3 months behind. So we're just starting to see January numbers now. So it doesn't really give you a good tracking. You know, if it's only 6 weeks behind, that would be different. But I can't change things that I did wrong 3 months ago or chase after those patients.
Okay. Paul?
Scott, I'm not sure how valid the numbers are because the last report I got, I had 3 categories that were red, weren't that good. The month before, I had all green except for 1. They just seem to shift around quite a bit from 1 month period to the other. In my mind, I'm saying, who's reporting the data? Is it comprehensive? Is there certain PBMs that are and aren't? It's just tough to validate, I think, right now.
Part of it is the number, if you look at the number that they pull, sometimes it's 8 people.
Right.
So, I mean, you do 150, 300 strips a day, you have 8 people.
All right, so and if anybody else, I just want to talk about what Equip is for those who don't know, and if anybody else has a comment, that's great. So Equip is a company that can give you a scorecard on how you're doing on your pharmacy measures. Where do they get the information? They get it from the insurance companies, okay? Not every insurance company is signed up. So hence, you might have 200 Medicare patients in your store, and you might only have 8 that are signed up with an insurance company that's reporting. As far as I know, Express Scripts does not report. They're the largest PBM. And I believe Optum doesn't report. So you got Caremark, who just came on recently, and then you've got a bunch of smaller ones. So the numbers aren't great. So you can have a problem when you only have 8 patients. Obviously, every time somebody is either in compliance or not, that's 12%. That can make a huge difference. So it's at the very beginning. I mean, 2 years ago, when I sold my drugstore, there was no Equip. We had no scorecard. So this is a wonderful thing. And, you know, one of the simplest tools of business management is if you measure it, it will improve. Right? You can't improve on something if you don't know what it is. So now we finally have something. To me, it's the second greatest thing in pharmacy. I think the first, to me, is medication synchronization, and we're going to talk about that later. But this is the second because you can measure and you can see what you're doing, and now you can start to identify the areas that you need improvement on or where you can help your customers with improvement. So with the Equip scorecard, which comes out at the 15th of every month, red is you didn't reach goal, green is you did reach goal. So, with this, you'd want to concentrate on the top two areas. But at least it gives you a chance to have an idea where to start. And the Equip scorecard is so important. There is a health plan in New York City. You have to meet certain criteria to get into this. Like you have to have 200 patients. You can't have 8. That is actually paying pharmacies $1,000 a year to look at their Equip scorecard once a month. You don't have to do anything. You just have to log on and look at it. And at the end of the year, they wrote out a $1,000 check. So somebody somewhere thinks it's important. And so if you get a chance, some of the organizations will help subsidize the Equip payment. So it's a great thing to have. Just quickly, this is just to show how the star ratings move. To get to be 5-star, to be the best plan. The top is the Medicare Advantage plans. The bottom are the PDPs. Those are the ones we usually work with most. So for high-risk medications, you want to get 6% to get to the highest level. But, 2 stars, 16%. But you can see, you want to we definitely want to get the medication adherence above 80%. Essentially, that means that people are taking the medication 6 days out of 7, and they're going to get the full effect of the medication. Okay, so those are the measures. How are you going to improve them, right? Because that's the whole thing. What can you do to make things better? I'll mention this playbook again. This thing is all about improvement. I would strongly recommend that you pick one up, just one per store, because they don't have a lot of them. But it gives you a lot of ideas and things that you can do to improvement. But you really need the whole pharmacy team involved, because you need to identify who the patients are. So you need your technician or whoever's running your filling computer to do the identifying. They need to know what medications they should be looking for. They need to know, you have to give them some guidelines about what's considered a late refill and when you should be concerned. Your targeted medication reviews, your TMR, which are Marixer and outcomes. The insurance company has actually identified that patient for you. So you want to do all of those that you can. Do every one that comes in, because that's attacking the pharmacy quality measures. So they've identified the patients for you, and then you just have to go through the process of finishing up the review. I talked about identifying the patient. Once you've identified a patient, you need to start the conversation with the patient, and that's where the pharmacist will be involved. Okay, if it's not taking their medication properly, you need to have a small conversation with why. We're adults, and we do what we want to do. So if someone is not taking their medicine, that's a choice they're making. They know they should, but they're making a choice, I don't want to take this medicine. And so to help them, you need to try to identify what's the stumbling block. Many times they don't understand the importance of taking the medication. Sometimes it's a timing issue. People forget the second metformin dose of the day. Well, that's an easy solve. There's an extended release that you can take both of them in the morning. So there are different ways that a pharmacist, and again, medication synchronization helps that immensely, but there's many things a pharmacy can do to help their customers take their medication. And then if it's something that needs a physician intervention, okay, you can have, get the permission of the patient, say it's a high-risk medication, get the permission of the patient to talk to the physician. There are some fax templates in here. Essentially, it's very nice verbiage that says, "Dear doctor, I know you're not a dummy, but this patient is on a high-risk medication. Do you want to change it?" And so you can fax it in, and they can bring it back. And that template is right in there. And again, you want to look at your Equip scores, because once you become aware of things, once you're aware that your medication adherence ratio for statins is not what it should be, then you can attack it. And you can have your staff be alerted to, okay, there's a list of statin drugs in here. These are the drugs Technician, I want you to identify everybody who is more than 10% late. So 3 days, right? 3 days late on a 30-day fill. Just identify them. Get it down to the pharmacist so that they can then go through the transaction history and find out, why they look. There could be many reasons why someone's late. But again, you can start the conversation with them. And then once they're aware that you're aware they're not taking their medicine, they're gonna be more likely to take it just for that factor alone. Oh, good. Okay, so I came to the end, and the timing wasn't bad.